Good afternoon, everyone. My name is Terry Wilt, and I'm the Director of Community Engagement for Mayo Clinic Health System in Southwest Wisconsin. Welcome to our first community forum of 2022, the COVID-19 pandemic. Where do we go from here? We know it's not easy keeping up with the COVID-19 pandemic. Variants, vaccines, testing, treatments, the news is ever changing. So today we continue our quest to provide you with current, reliable information to help you navigate this challenging landscape. One of the benefits of a virtual event is the ability to reach a broader audience. We want to thank WKBT News 8000 and WXOW News 19 for live streaming today's presentation. We're also grateful to the more than 900 people from near and far who registered to attend via Zoom. We've received more than 100 questions from our Zoom attendees, and you can continue to submit questions throughout the forum using the Zoom Q&A function. Because of the volume of questions we've received, we'll be focusing on common themes. But even if we don't answer your specific question later in the program, chances are we'll cover the topics you're most curious about. We're fortunate to have three Mayo Clinic experts sharing their knowledge with us this afternoon. Our panelists include Dr. Abinash Virk, a Mayo Clinic infectious diseases specialist and professor of medicine in the Mayo Clinic College of Medicine and Science. Dr. Virk also serves as co-chair of the Mayo Clinic COVID-19 vaccine work group. Dr. Raj Palraj is a Mayo Clinic infectious diseases specialist and a member of our Southwest Wisconsin team. He has been on the front lines of COVID-19 since the pandemic began and has been featured in numerous regional news stories. Finally, Dr. Paul Mueller has served as Regional Vice President for Mayo Clinic Health System in Southwest Wisconsin since 2018. He's a professor of medicine and a professor of biomedical ethics in the Mayo Clinic College of Medicine and Science. And now we'll turn to Dr. Mueller to begin today's program.
Well, thank you, Terry, and thank you for all your help in organizing these very important forums. And I do wish to greet our guests and welcome you to this forum, and also thank our presenters today, Dr. Virk and Dr. Palraj. We'll go to my first slide. As in other forums, I've given you the current state of the COVID-19 pandemic, and you'll recall that use of the word 19 or the number 19 has a reason. It's been now several years since this virus emerged and on the global scene. The map you see of the United States looks a bit different than the one I presented to you several weeks ago, where there was a bit more yellow and some blue and more orange. We have widespread exponential transmission of this virus nationwide. And when a county is red, that's when you have more than 100 cases, new cases per 100,000 in the last 7 days. I took the number from the CDC for La Crosse County yesterday, and the number they have is 2,163 new cases per 100,000 people in the last 7 days. So we are at the high level. The graph at the right shows you the daily cases, and each line represents 200,000. And if you go to the far right, you see an exponential rise of daily cases just in the last few weeks. You also see daily deaths, and each line represents 1,000 daily deaths nationwide. And you're seeing an uptick to the far right as well. Next slide. So some data. If you recall, last time I gave you these numbers, and you'll notice some changes. To date, there have been 62 million known cases of COVID in the United States with 837,000 deaths. That's a staggering number for our country. Nearly 80% of people aged 5+ have received at least one vaccine. And now the Omicron variant accounts for 98.3% of cases. Just last December 4th, it accounted for less than 1% of cases, and the Delta variant is now only 1.7% of cases. So clearly Omicron has taken over. Unvaccinated persons clearly have higher risks for testing positive, being hospitalized, and dying from COVID-19. And you see those graphs to the right. Again, this is from the CDC website yesterday. The upper graph shows age-adjusted rates of COVID-19 hospitalizations according to vaccine status. You can see in the blue line, unvaccinated persons have a much higher risk for hospitalization than those who are fully vaccinated. And then the boxes below show differences between unvaccinated people and fully vaccinated people testing positive and dying. And then compared to fully vaccinated persons who've received a booster dose, the difference, they're 10 times more likely to test positive for COVID if you're unvaccinated and 20 times more likely to die. Hospital and health systems are busy. We have lots of COVID patients, but we have lots of patients with non-COVID illness, much of which has been delayed. The people we're seeing in the hospital are primarily unvaccinated, and prevention remains essential, therefore. Masking, social distancing, hand hygiene, vaccines, and boosters when indicated. And then we'll hear today about novel treatments that have emerged. Next slide. So this is to welcome Dr. Virk, Dr. Palraj. Thank you. I've known these individuals for many years. Nobody knows more about infectious diseases, and in particular this virus, than these two fine colleagues. So I'll let Dr. Virk take it over.
I'll cover some of the new information about Omicron and what kind of impact it's having and what can we think of in the future. Dr. Mueller already covered that globally cases are increasing very rapidly. This slide I made on January 3rd, you can see that the numbers were, going up dramatically. This slide is already obsolete because these numbers have already gone up since that slide was made. And in the US, again, just to kind of reiterate what Dr. Mueller said, by January 1st, 95% of what we were seeing in the US was Omicron. And I want to highlight that, and I'll highlight that in a subsequent slide, because I think it's really important for us to understand the difference between Delta and Omicron. And I want to start a little bit with the science part of things. And what I want to highlight here is that this is a schema of what the SARS-CoV-2 virus looks like. There is the spike protein, which is really important for it, for the entry into human respiratory cells. And it's the antibodies against this particular spike protein, and particularly for this area, which is called the receptor binding domain, that's really important for preventing the virus from entering into the respiratory cells and preventing that infection from happening. And what we see about these viruses is that, and this is a normal thing for the virus, it mutates really quickly. The example I give people is it's sort of like if you're making a photocopy of a page and you make 100 photocopies, a couple of the pages are going to be smudged. That's because it's a very rapid process and there are mistakes that the virus makes. Some of these mistakes are essentially nonsensical mistakes. They really don't make any difference. But some of these actually increase transmission, increase severity, or have other implications in regards to treatment and those kind of things. When they are localized and they're spreading only in a smaller area, those we call variants of interest. And those that have definitely increased evidence of transmission or increased level of severity or difficulty with the treatments or prevention and are spreading globally quite a bit, those are called variants of concern. And thus far, in the world, we've had about 5 variants of concern, with the Omicron being the most recent. What I want to highlight to you here is that this slide you can see is only from January 2021 through January of 2022. It doesn't even have everything from 2019 through the end of 2021. What you see here is that there are new variants coming in and going out. Some get edged out by the new variants. For example, the Alpha, which was kind of the big one, which was originally from UK, got edged out. Even the Beta, which was South African one, that got edged out. And it really got edged out by Delta because that was more transmissible. But Delta also had more maybe equivalent severity than the previous variants. And now we're seeing the kind of the entry of this new Omicron, and we don't know how big this wave is going to be, but potentially it may be bigger than even the Delta wave that we saw. And there's some rationale for why I say that. One of the important things about these mutations is that as time goes forward, so this is December 2019 in the left corner, and on the right corner is December 2021. As time has gone by and as more and more variants have occurred, these variants have accumulated more mutations. So, if we go from 0 and we are here in January of 2022, you can see that the number of mutations which are on the y-axis have continued to increase. And these mutations are in that receptor binding domain, which makes the virus enter the cell and cause the infection, and that these mutations then have impact on our vaccine prevention and treatments and those kind of things, and also have higher transmissibility from one person to the other. Here's kind of the schemata from the World Health Organization that shows you all the mutations and the 5 variants of concern. You can see alpha has just a few, but it has quite a few. Then you have beta, gamma, and delta. But then here's Omicron, and you can see that it clearly has a lot more mutations and therefore likely has implications for transmission and treatment. Historically, based on what we learned about Delta, was that the vaccines were still very effective and the treatments were very effective, and all those little mutations that we had didn't make that much of a difference, although it was more transmissible than the previous variants. But the Omicron is a whole different thing. So how do we know that Omicron is transmissible? So there are 2 rationales for us to say that. Number one is scientifically, based on these mutations that Omicron has, the ones I just showed you, some of these mutations increase the ability for it to attach to the receptor that allows the virus to enter the cell, and therefore it allows more virus reproduction and allows the transmission to happen. So we know that based on the mutations itself that yes, this is probably going to be more transmissible. The second is the clinical basis of what we are seeing. And I will share with you what has happened over the last essentially 2 months. The first case ever of Omicron was on November 9th. That was the first time ever that anybody knew that there was Omicron. By November 26th, which was less than 3 weeks, there was enough Omicron in South Africa spreading so rapidly that the WHO called it a variant of concern. And essentially, by the next week, on December 1st, we had our first case travel related in the US. And on December 2nd, we had a very important finding that was the first case of Omicron in the US with somebody who had not traveled outside of the US or had contact with somebody else who had traveled outside of the US. And this was somebody who had traveled to New York City for a meeting. And that just tells you how quickly it's moving. The second evidence that we, again, I think we all kind of know based on all the curves we've seen, but this is just to kind of highlight the difference between Delta and Omicron. The 0 to 95%, meaning is from 0 of Delta to 95% of all proportion of SARS-CoV-2 infections in the US being Delta took 12 weeks to occur. Whereas when you look at Omicron, it only took 6 weeks from December 1st through 2nd of January, we were already at 95%. So it's obviously transmitting very, very quickly and moving fast. What about diagnosis of Omicron? PCR tests are very good against the diagnosis of diagnosis of the COVID-19 caused by Omicron. It won't specifically tell us it's Omicron, you need additional testing, but essentially you can make the diagnosis that this is COVID-19 versus influenza or something else. The antigen test may not be as sensitive, particularly in the early part of the infection, because the virus amount may not be high enough for the test to actually pick up that protein that we are trying to pick up. So repeating the test is important. Now, the one thing I want to highlight about the antigen test is that if it's positive, it is very specific and it tells the person that they have COVID-19. If it's negative, they shouldn't take reassurance that, oh, they don't have COVID-19, but they really may need to retest themselves in a short order in 24, 48 hours particularly if they've had exposure or they met somebody who had, COVID-19, to make sure that they can do additional precautions. What about symptoms? So this is a very interesting study that was published very recently. And this looked at the the second person who came into the United States. He had, who got Omicron in the United States, who had COVID-19, and he had previously had COVID-19, and he or she, I don't know if it was what the gender was reinfected. They have 6 household members. 2 of them had never had an infection and were not vaccinated, and they got the infection. 4 of them had had prior infection, and of those, 1 of them was vaccinated, and all of those people also got infected. And they studied all of this little household to see what's going on with Omicron. What they found was that the onset of infection was 73 hours. So the range was 33 to 75 hours amongst these 6 people. The ones who were previously not infected, they had more symptoms. They had cough, joint pain, congestion, fevers, and chills. The ones who were previously infected and or had the vaccine, that one person, they essentially had milder symptoms. They lasted shorter, and they didn't have any loss of taste or smell, which is what we're seeing in the large number of patients that we're now seeing. What this study really told us a few things. Number one, that it's the incubation period, or the time from exposure to infection, is shorter than what it was for Delta. So it's 3 days versus 4 days. And prior to that, with the Alpha, it was 5 days. Number two, it's highly transmissible, another kind of piece of evidence. And number three, that previous infection or vaccination doesn't totally protect you from infection, but may decrease the severity of the symptoms. And so the question is, who is right now getting these infections? Where are all these infections? So I want to highlight this particular slide. This is a very illustrative slide. What it shows you is that there are cases happening, peaks happening in each age group as we look at the US population. But when you look at the percent of vaccination, so in the older population, the vaccination rates are higher than 80%. Their peaks are much lower than they are with the other age groups that we see. So the lower the vaccination rates, kind of proportionally, their infection rates are a little bit higher than the ones that have had a higher percentage of vaccination in that group. What about severity? Hospitalization and death data tend to lag behind a little bit. But what we are seeing over and over again from the US as well as from other countries is that the hospitalizations proportionally are less than what we saw with Delta. But the reason why we are having increase in hospitalization rates overall is because the number of infections, just the large volume of infections, is much higher. But the proportion of how many people are landing up in the hospital and dying is still lower. What a recent study from UK showed was that Omicron hospitalizations were half of that of Delta, and that if somebody had been vaccinated compared to unvaccinated, similar to what Dr. Mueller just said, and this is specifically pertaining to the Omicron infections, that the reduction in hospitalization was 81% after 3 doses of the vaccine, compared to 65% after 2 doses of the vaccine. And this is the curve that Dr. Mueller already showed, so I'm not going to go over that. But I will show you another set of curves. This is from our world in data, and this is showing I'm showing you the 4 different countries. Here is the United States in, United Kingdom in green, and the pink here is South Africa, where their curve of infections has gone down. But in UK and Israel, the infections are going up fairly rapidly. But when you look at their hospitalizations, their death rates over per million, so it's standardized per million, what you see is, compared to the previous wave, which was the Delta wave, the death proportions are much lower. Of course, we shouldn't take solace in that, because we still have lots of people who are coming into the hospital and who are sick with this illness. What about vaccine effectiveness? What I want to show you here is this is another study, which is a preprint. That means it's not been peer reviewed. That was submitted recently from United Kingdom regarding Omicron, since the Omicron vaccine effectiveness with 2 doses or with a booster. So what I want to show you here is that on the left, you have the AstraZeneca vaccine, and you compare Delta versus Omicron, and they did not have enough cases in the Omicron group, so they can't really make much conclusions. But what they showed was that even against Delta, AstraZeneca by about 15 to 19 weeks was only about 50% effective. On the right hand here, you have Pfizer. So 2 doses of Pfizer compared to Delta and Omicron by about 15 to 19 weeks in this salmon color. You can see that there was 72% protection against symptoms, and against Omicron, it was only about 34% after 2 doses. But when you added boosters, you see that the booster really gave additional protection from symptomatic Omicron infection. Here's another set of data that was also recently published that looked at virus, neutralization of virus in people who had 2 doses of the Pfizer vaccine, and then after a booster. What you see here is that compared to Delta, which is compared to the original strain of SARS-CoV-2 on the left, the Omicron neutralization is really poor, but it does improve significantly after the booster with the Pfizer vaccine. Similarly, for people who previously had an infection who then get a booster with the Pfizer vaccine, their pre-booster neutralization of the virus is pretty low, but it does increase with the vaccine booster. So the point here is that previous infection is unlikely to protect people from infection with Omicron, and this is what we saw in South Africa. There were a number of reinfections. Another piece of evidence, this is from South Africa, where they compared 2 doses plus a previous infection with a previous strain. They saw very good neutralization of the virus, but it was substantially reduced against Omicron. But when they compared people who only had 2 doses of the Pfizer vaccine, the old strain was really very effective, but with Omicron, there was very little neutralization. So again, giving us evidence that Omicron in itself does decrease vaccine effectiveness, but having an infection or another booster after 2 doses does increase that protection quite a bit. Similar studies have been released by Moderna and Pfizer, suggesting that the antibody levels really increase substantially, particularly the neutralizing antibodies after a booster. This is just on press release that I have seen. There was a study from South Africa looking at the J&J vaccine and a booster after 1 dose, 6 to 8 months after the first dose, showed that it was 85% effective against preventing people from getting into the hospital. And this is the most recent data. This is data specifically for Omicron in the United States. This data is from New York State Department. It's public information. And what they've been tracking is the rates of hospitalization, rates of vaccine effectiveness overall, new daily cases and hospitalizations on the right per 100,000 population, based on fully vaccinated, the red, and the unvaccinated in blue, and the vaccine effectiveness in the black line. What you see here is that overall prevention of infection is about 77 to 79%. And obviously the risk of infection is much higher in the unvaccinated individuals. And this is looking specifically at Omicron, which is this gray bar here. And then when you look on the right side in terms of hospitalization, the protection against hospitalization is still very well maintained against Omicron. But again, unfortunately, the risk is higher among the unvaccinated compared to the vaccinated within this Omicron period. So what about the fourth dose? Do we really need it? The answer is we really don't know that yet. Obviously, you know that Israel is doing it, and they've shown that antibody levels increase further, but we don't have all the information about this yet. How can we protect ourselves? I'm going to sound like a stuck record, and I'm going to say it again, that it's really vaccinations, that we need the vaccinations to protect people. Vaccinations are not new. Vaccination requirements are not new. They've been going on for decades and millennium at this point. Well, not millennium, but for a long time. And here are all the timelines of COVID-19 vaccination authorizations and recommendations. And over the last year and a half, since December of 2020, a little bit over a year at this point, we've had so many in-depth reviews and recommendations that have responded to new information and updated recommendations, including the additional booster dose, additional dose number 3 to immunocompromised individuals, and the subsequent booster recommendations for various age group populations. The most recent being that the boosters for 12 to 15-year-old children should be also given boosters. The booster interval has been decreased to 5 months, and all children and people over 5 years of age who are immune compromised should receive the additional dose. So it's the 3 doses followed by a 4th dose, which is the booster. So in summary, at this point, everyone is recommended to get a booster. We are giving recommendations for mostly for the mRNA vaccines are the primary ones. Those that got J&J should get any of the 3 as the booster. But this is kind of the schematic I want to share with everyone to remind them for people who are immune compromised. There's the first dose of the mRNA vaccine, followed by the second dose, 21 to 28 days later. There's a third dose given at 28 days after the second dose, and then a booster 5 to 6 months later. The reason why many people are confused about this dose was because at the time it was approved back in August of 2021, it felt like it was a booster because most of these patients had received their primary series months ago, but it was not the booster. It was the number 3 dose, and they now should go and get their boosters 5 to 6 months after. So in summary, Omicron is highly transmissible, seems to be milder disease compared to the previous variants, particularly in the vaccinated individuals. Getting a booster would definitely increase your protection. And Dr. Raj will talk about the monoclonal antibodies. And certainly we will see some degree of co-infection, as we've already seen patients who have had influenza and COVID-19. And so we recommend everyone getting vaccinated. Will we see future variants? Yes, we will see future variants, but we don't know how they will, what kind of disease they will result in. With this, I'll turn it over to Dr. Palraj.
So that was a great amount of information about the Omicron variant by Dr. Virk. I'm going to touch on a few points that Dr. Virk already emphasized. So the Omicron variant, after being detected in South Africa, has spread all over the world now. And we know that it's much, much more transmissible, almost like 2 to 4 times than the Delta variant. In preliminary data from UK, South Africa, and Europe, as Dr. Virk showed us, it at least promises to be less severe disease compared to the previous Delta. Causes smaller proportion of people to be in the hospital, smaller proportion of people needing oxygen and intensive care unit. And one of the reason we believe that it's less severe is animal studies have shown that the Omicron variant predominantly infects our nose and throat, rather than the lung tissue. So it causes less severe pneumonia compared to the Delta variant. Next slide. So where do we go from here? Is it the beginning of the end of the pandemic? It spreads much faster and much more transmissible. So most likely even the unvaccinated population have a higher chances of getting infected. And everybody has been speculating whether this will result in herd immunity. There is a possibility that even the unvaccinated, if they get the Omicron infection, hopefully they have mild infection and recover. And if they have immunity, that will help this virus to become like endemic, and it will have herd immunity. There are preliminary lab data showing that uh, the immunity that people get after a Omicron viral infection has some amount of protection against the Delta variant and the other severe strains. So this might be a silver lining of this Omicron surge. Next slide. And as Dr. Virk showed before, in South Africa, the Omicron surge peaked within 4 weeks and came down quickly. And in the UK, compared to the previous week, last week, the number of cases have started to decline. It was 13% lower than the previous week. Again, it's a preliminary information. So there is a chance that the Omicron surge may peak and come down very quickly as well. US is different. It's a large country, and every part of the country has variable vaccination rate among the population. The number of vulnerable population might be different in each part of the country. So even though it's less severe, as Dr. Virk emphasized, I want to re-emphasize this again, even though a smaller proportion of those infected need hospitalization, because of the rapid rise and the huge amount of vulnerable population we have, the number of patients will and have been overwhelming hospital systems. And we also have to deal with staff absences. We are seeing that in healthcare setting as well as in other essential care settings. So even though the Omicron surge may eventually lead to or probably herd immunity, it comes with a huge cost. In the next few weeks, we will see more hospitalizations and death among vulnerable population. Next slide. And this has been touched on previously by Dr. Mueller and Dr. Virk. The Pfizer and Moderna vaccines, even though they may not prevent mild infections, they are very good in protecting us from severe disease and death and hospitalization. So that's one point that we have to keep emphasizing again and again. The booster doses and the vaccinations are the most important thing. Prevention is better than cure. And so I will touch on two COVID drugs that have been kind of developed in the past few months. The Pfizer has developed a drug called Paxlovit. It's a protease inhibitor. It inhibits the protein formation by the virus, and it's a very, very effective drug. It results in 89% reduction in hospitalization if it is started within 5 days of symptom onset. And that's a great news. We have the monoclonal antibody, sotrovimab, which still remains effective against Omicron. Unfortunately, two other monoclonal cocktails, including the Regeneron, do not have any effectiveness against Omicron. So we have only one monoclonal antibody regimen, and that still approximately reduces 79 to 80% hospitalization. The third outpatient drug or option we have is the molnupiravir. It's developed by Merck, and it's a RNA polymerase inhibitor, and it results in slightly lower 30% reduction in hospitalization. So it's not as effective against Pfizer, but it's still something that we can use to reduce the number of people getting hospitalization. So even though we have Pfizer drug molnupiravir and monoclonal antibodies, we are still dealing with limited amount of supply at this point. Uh, the US federal government has promised to buy 20 million doses of Pfizer drug, and they are supposed to be delivered by June of 2022. But at this point, for the next few weeks, we won't have enough supply to turn around the Omicron surge. Same thing with the monoclonal antibodies. We are reserving the limited supply to the highest risk category. So these drugs are great and they will have an impact later in the year, but during the current Omicron surge, they will not have a significant impact. And that's why it's very important to have our basics, common sense infection prevention, get vaccinated, get booster, use mask, avoid crowded indoor settings, and hand hygiene. And that's all I have, and we can open it for questions.
Well, thanks, Dr. Virk and Dr. Palraj. You can see why it's just a joy for me personally to work with such outstanding colleagues, because just a phone call or a text away, I have the world's experts at my hand to take care of patients. So Terry, we have questions, I'm sure.
Oh boy, do
Let
we
me
have
start
questions.
may I start with one? Okay, I'm a patient. I got my 2 vaccines for primary series, and now I got Omicron. I'm convalescing, I'm getting better. When should I get my booster?
I would recommend getting it as soon as possible. There's no reason for you to wait. If somebody got a monoclonal antibody for the treatment of COVID-19, then yes, we still want to wait for 90 days. But if somebody didn't get COVID-19, didn't get the monoclonal antibody, they can go ahead and get the vaccine as soon as they're out of isolation.
Great, go ahead, Terry.
Okay, well, we have tons of questions, and I'm going to rely on Dr. Mueller to help direct the questions to the appropriate panelists for the initial response, and of course, others should feel free to respond as well. Given the title of our forum is the COVID-19 pandemic, where do we go from here? I want to be sure we spend some time talking about what the future may look like. So let's start with this question. Will the pandemic ever end? When and how could it end?
I think Dr. Palraj touched on that, and there may be a silver lining in the current Omicron surge. I mean, the numbers of people who are currently carrying the virus and are asymptomatic is very high, and there's some estimates that maybe Dr. Palraj and Virk can, because I don't want to give the wrong numbers, but the number of people who are will be infected by this variant is extremely high, and the likelihood is that unvaccinated people or people who aren't masking will be infected. So will that lead to widespread herd immunity? The question remains to be seen. Of course, we want everyone to be vaccinated and boosted. That's also our best hope for protection. I guess the other thing, this is so prevalent in our communities now. Remember, I showed you the La Crosse County data of the transmissibility over the last 7 days. It's so prevalent. You should assume that people around you in the community, the grocery store, the gas station, are infected, even if they don't have symptoms. But maybe Raj and Abinash, you want to talk about when does this pandemic end?
Yeah, I saw a recent estimate from WHO scientists yesterday, and they are expecting almost half of European population, the entire European population, very similar to us, around 300 million, will be infected by Omicron in the next 6 to 8 weeks. So this is a highly transmissible infection. And if people are unvaccinated, there is a high chance that they will get the Omicron virus. Being optimistic, I think we can hope that most of them or have mild infections and they will develop immunity. And if we go with that optimistic assessment, the silver lining of the Omicron surge in the next few weeks will result in significant level of immunity in our population. Again, there are so many variables in this assessment Obviously, there might be a new variant around the corner, so it's very hard to predict. But the optimistic prediction will be um, we might have some level of herd immunity in the next few months.
Could I add to that? So I think, the question is, will this end? And this, I would assume the question is SARS-CoV-2, COVID-19 as a whole. And I am, I think at this point, it's difficult to predict whether we will ever have the no COVID, no SARS-CoV-2 circulating status because of the volume of people that are infected worldwide, whether it's Omicron or Delta or something else. So number one, we have a lot of virus floating around. That's number one. Number two is that we have a large number of population, vaccinated or not, that are susceptible to the virus still. Yes, it may not kill people, but they can still get the infection. They can still transmit the infection. Number three is that, unfortunately, the vaccines don't provide absolute protection. So they don't provide, so if I give somebody a vaccine and that means they're never going to have an infection, unfortunately, that's not where we are. There are other vaccines for other diseases like hepatitis A, et cetera, that once we give people the vaccine, they are protected rock solid, but that is not happening and unlikely to happen with any of our COVID-19 vaccines at this point. We don't know. Maybe there'll be something more in the future. And the fourth reason why I think that we will never probably get rid of SARS-CoV-2 is the recent data has suggested that the SARS-CoV-2, particularly with the more recent variants, has adapted to infections in animals. So they've shown that mice, the receptor that's needed for the virus to enter into the cell, the mice have it also, and it attaches really well, and it enters mice respiratory cell as well. And similarly with other, there's other animals or birds that potentially can get this infection. So that risk is there that there may be a non-human reservoir to have this virus come back into the circulation. And the fifth is that these viruses continue to form new variants, and sort of like influenza, we are protected against influenza to most part, but there is always a little tweak to that influenza every year such that we need a vaccine. So it's quite likely that in the future we will be looking at like an influenza-like state for a SARS-CoV-2 infection.
And of course, then that would have implications potentially for when you get your influenza vaccine, you get your COVID vaccine, depending on what the variants are circulating.
Yeah.
Thank you, doctors. There are a lot of questions regarding the new CDC guidelines for the 5-day isolation. This person wants to know, do we agree with it? And someone else is asking, does the 5 days begin when symptoms start or when a person tests positive?
Abinash or Raj, go ahead and take it.
I think, those recommendations are challenging. I think they make sense for particularly people who have mild symptoms, that the likelihood that they will be transmitting the virus beyond 5 days is pretty low. So I think those recommendations may have to be tweaked based on what kind of person it is who is infected, and what kind of symptoms, whether they're vaccinated or not. And then the question has also been brought up, should we be testing people at the end of the 5 days? And I think that's another question that we don't really know the true answer for. And in regards to whether we should start the 5 days from symptom onset or 5 days from test, at this point, I think it would be better to take the conservative view and say whichever comes last, presumably the test came later. Don't know if, Raj, you have other things to add.
Yeah, I agree. I think it's kind of a balancing act that the CDC and the public health officials have to do. We know that from all the data that most people are highly transmissible in the first few days of symptom onset. And after 5 days, the risk of transmission goes down dramatically. It's not zero, but it goes down significantly. So if we say we have to wait for 10 days so that we reduce the risk of transmission to close to zero, then we are looking at a lot of absences in the essential services, in the hospital community, and so on. So we are trying to reduce the risk of transmission by going with the 5 days, which is the most transmissible period. At the same time, allowing the essential services to continue.
And it really, you still wear the mask. Remember, early in the pandemic, we said, wear the mask to protect others, so you're not spreading it around. Not so much protecting yourself, although you want to do that now with our tighter masking guidelines, surgical masks and so on. But wear the mask, and after that 5 days, you heard the risk is much lower, but then you can reduce that by masking, social distancing.
Okay. Let's see. What's the best way to treat symptoms at home, and when should I seek medical care?
Raj, you want to start with that? And then actually, what should they do if you think you're infected? What should people do?
Yeah, great question. I think for mild symptoms, the common symptomatic support, keep yourself hydrated, drink a lot of fluids, similar to what we do for flu or common cold. If you have little fever, you can have the over-the-counter medications to reduce your fever, keep yourself hydrated, make sure your breathing is fine. And if you feel short of breath, that I think that's the most important red flag that you need higher level of care. You need to call your primary doctor or nurse line to kind of tell your symptoms, and they will help you to understand whether you need to go to the hospital. So I would say, if you have symptoms, try to get a home test. I would like to say that if the symptoms are mild, please don't come to the emergency department because they are busy. Do a home test or go to a dedicated COVID PCR testing center. And based on the symptoms, you can call the nurse line or your primary clinic, and they will help you kind of navigate the situation. In terms of COVID drugs, I think right now they are limited in supply, and we are limiting it to the people with the highest risk of severe disease.
Yeah, Mayo Clinic Health System's website has a symptom check application, and you can call our COVID-19 nurse line at 507-293-9525 and get directions if you need testing, etc. But to Dr. Raj's point, don't go to the ED because they're busy, but you may also spread the virus to vulnerable people. Dr. Virk, any comments?
Yeah, so one of the other things I would add is that if you have symptoms, particularly right now until say March or so, it's important to get tested. And most of our tests at this time, we're testing both for influenza as well as COVID-19. And it's actually really important to know whether you have influenza or COVID-19 because treatment approaches and isolation approaches are different, but the symptoms may be very, very similar. And so early, if you have symptoms, call the nurse line. They will arrange for you to have a test. All of our Mayo Clinic testing right now tests for influenza and COVID-19 at the same time. And if people are high risk, meaning that they are immune compromised or elderly, then we also test them for RSV as well with that same test.
Okay, thank you. A lot of our viewers are interested in the change in masking guidance that's occurred recently, and specifically are wondering what's up with the cloth masks and where did that guidance come from?
Dr. Virk?
So we know that cloth masks, particularly two-ply, meaning two-layer cloth masks, are not as effective in preventing transmission or, allowing some of those droplets to go through. And certainly I've seen patients who have had gaiters that are knitted gaiters, and those, will not be effective for preventing some of those droplets to go through. And that is the reason why we are currently not recommending the cloth masks and gaiters, because we know that Omicron is much more transmissible. We just need to control this whole situation. And therefore, we are currently recommending surgical masks and then N95 only in certain situations right now.
Thank you. Is there any new vaccine research to report on? Are new vaccines in development that could change the course of the pandemic?
Yes, there are a number of new vaccines that are currently being developed, and that's the beauty of the mRNA platform for vaccines. So the Pfizer and Moderna and others are working towards developing a variant-specific vaccine, and so are some of the others. And also, in the future, many of these are also looking at multiple vaccines addressing multiple common respiratory viruses. So, can we have one vaccine for flu and COVID-19 and those kind of things? So there's a lot on the horizon in regards to respiratory viral vaccines.
A follow up on that, Dr. Virk or Dr. Palraj, vaccines for the very young children. I ask this every forum when lots of questions from patients, etc.
Earlier, we had heard that we would hear information by sometime this month, but I believe that has been delayed a little bit, and I don't have a specific timeline, but sometime this spring, we should have more information for the younger children less than 5 years of age.
In follow-up of that, we've said that this variant spreads like wildfire, and unvaccinated are pretty vulnerable to infection. And last I checked, kids under age 5 are zooming around a lot. What are you seeing with the pediatric population? Any comments regarding that? What safety measures could be done?
I don't have specific data for under 5, but they are vulnerable since they're not vaccinated and also have more difficulty wearing the mask. The rates of infections are still lower than the adults, but that's really all I can add right now.
A somewhat related question, are newborns protected if mom has been vaccinated?
Yes, so that's a great question. I recently saw some studies that showed that maternal antibodies do actually transfer to the child. So the child is generally protected through some degree of antibody through breast milk and also through transplacental for at least the first 6 months after birth.
And that's consistent with other types of infection, right?
Yeah.
And another popular question concerns travel. If you're fully vaccinated and boosted, is travel okay?
What do you want to? You want to?
Go ahead, Dr. Virk.
Well, so if you're fully boosted, fully vaccinated and boosted, as we showed, that definitely boosting does give you additional protection. How much protection is yet to be kind of, we're still studying it. We're still trying to learn how much protection does that really give, but clearly more protection. Will that completely prevent you from picking up Omicron? I don't know. You might still have a kind of a mild infection. I would say and I would do this for myself, if I was traveling locally, domestically, or internationally, and I'm boosted, I would definitely wear a mask to prevent myself from getting infection. The risk of traveling and getting infected, especially in other countries, is then if you really get unlucky and become severely ill, you are then in a different country with possibly different language, healthcare systems, and treatment protocols, and the likelihood of being airflown back to the United States would be low. So I think those are the kind of things one has to think about when you're thinking of travel, whether it's domestic or international.
Okay, so we want to be mindful of people's time, so I'm afraid we're going to need to end our discussion there. But before we wrap up, one more time, Dr. Mueller, do you have advice to share with our audience about staying well during the Omicron surge?
Well, how to protect yourselves, others, our communities, your loved ones, and our health systems. And along the lines of the travel question, you can do things in the community, you can go places, you can go to events, but you have to do the best you can and assess the risk. And the way to lower that risk is to get vaccinated. So if you're unvaccinated, get a COVID-19 vaccine. If you are vaccinated, get a booster. You already heard if you were infected and you need a booster, you don't have to wait to get that booster. Wait till you recover from the infection and you're able to circulate and then go get your booster. As an aside, get the flu shot too. You can get both at the same time. And I got both, one in each arm. And so that's doable, because if you're infected with flu and COVID, that dual infection can be tricky, but get both. And as I said earlier, assume others in the community are infected and contagious. This is spreading like wildfire. And when you're seeing people out in the community, just assume they have it and then act accordingly. So wear a mask. You do that to protect others and yourself. Socially distance, avoid crowds and poorly ventilated places. Wash your hands and use hand sanitizer a lot. Cover your coughs and sneezes. And monitor your health. And if you're symptomatic, get tested, but not in the emergency departments. There are testing centers available. Call your provider. In La Crosse County, the county health department website also can give you a list of places where you can go. You can use home kits. As Dr. Virk and Paul Raj pointed out, if that home kit is positive, you've got COVID. Just call your doctor on what to do, or your provider on what to do next. So thank you for your attentiveness. We hope this forum was informative to you. We will continue to do this as part of our mission. I'd like to thank Dr. Virk and Dr. Paul Raj for joining us today. And of course, Terry Wilt, who is the big planner behind all of this. Have a great day. And Terry, you have some final words.
Yes, I just want to let our Zoom registrants know that they'll receive a follow-up email with a link to a recording of this presentation. If you're watching us via live stream, please email us at the address on your screen and we'll be happy to provide you with the link as well. Please also use that email to share any feedback about the event. We'd love to hear from you. This concludes today's program. Thank you and have a great afternoon.